From the JAMA Network, this is JAMA Internal Medicine Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Internal Medicine.
Hello and welcome to our listeners around the world. This is Dr. Eve Rittenberg, and you're listening to JAMA Internal Medicine Author Interviews. Thanks for joining us. We have two fantastic guests today to talk about their studies that examine different aspects of the opioid epidemic, specifically what happens to people with opioid use disorder who are hospitalized in the U.S. And opioid use disorder has a profound impact on people's lives and well-being in the U.S. And one of the frustrating aspects of the opioid tragedy is that we know that medications to treat opioid use disorder are effective in reducing overdoses and mortality, but most people with opioid use disorder don't get medication treatment, even if they're in the hospital, which you would think should be a place with knowledge and resources. So to talk to us about both the impact and some potential solutions to this gap in care, we have two guests. Dr. Itai Danovitch is the senior author of a randomized controlled trial examining the effects of an inpatient addiction consult service on treatment of opioid use disorder. He's professor and chair of the Department of Psychiatry and Behavioral Neurosciences at Cedars-Sinai in California. And welcome, Dr. Danovitch.
Pleasure to be here.
And we'll also chat with Dr. Michael Incze. Dr. Incze is the author of a study evaluating the timing and cause of mortality among veterans with opioid use disorder following medical hospitalization. And I'll note that these two studies are published side by side in this week's issue of JAMA Internal Medicine and make a really interesting complementary read. Dr. Incze is an associate professor in general internal medicine at University of Utah School of Medicine and the clinical review and education editor at JAMA Internal Medicine. So welcome, Dr. Incze.
Thank you so much, Eve. Grateful for the opportunity to join today.
Thanks. So let's start with Dr. Danovitch. Itai, I'm going to ask you to dive right in and tell us about your study. And then, because Mike's study sort of shed some light on why it's so important, I'll ask him to share his findings as well.
Sure. Well, in my clinical practice, I'm an addiction psychiatrist, and I practice in a hospital setting to a large extent. On a daily basis, on a regular basis, I would encounter patients who had substance use disorders and opioid use disorders who were admitted for a range of medical consequences or health problems often related to their opioid use disorder. And the hospital that I'm a part of would do an absolutely spectacular job of treating infections, of reversing the consequences of overdose, of managing a whole host of critical medical conditions. And yet we would consistently fail to initiate treatment for opioid use disorder and other substance use disorder, or to effectively link people to aftercare. So that was an opportunity, and I had the opportunity to join together with a close colleague, Allison Ober, who's an implementation scientist, and together we developed an intervention that would systematically try to improve the delivery of evidence-based interventions to hospitalized patients with opioid use disorder.
So I was really interested to see that you had a number of different pieces of that intervention. It wasn't just handing people a prescription. Can you tell us a little bit about what your intervention was?
Sure. Our intervention is a type of addiction consultation service. And there's a lot of different ways that addiction consultation services can be put together. We put together an addiction medicine specialist, which is a physician that is capable of managing opioid use disorders. And we intentionally defined it broadly, so it wasn't only people that are board certified in addiction medicine or addiction psychiatry, though that's optimal, and a care manager. And each of those roles would deliver evidence-based interventions that included not just medication treatments for opioid use disorder, but motivational interviewing and an evidence-based approach to linking patients to aftercare. We put these together in a manual, and we will soon be publishing that manual so that we would have an intervention that could be replicated. That, in a nutshell, is what the intervention was.
And so then what did you find when you delivered this intervention to some of the folks in your hospital?
We found that compared to usual care, the intervention was substantially effective in initiating medication treatments for opioid use disorder and linking people to aftercare. And this was despite the fact that the population that we treated across 3 different sites representing 3 different regions of the United States, was really a socially disenfranchised population. Some of the people that you think of that have the greatest barriers to linking to aftercare. Over half of the patients that we took care of were unstably housed. 84% of the population that we took care of had a public payer as their insurer. And there was a lot of psychiatric comorbidity and a lot of comorbidity with other substance use disorders and medical conditions. So despite having a fragile patient population experiencing a lot of disparities related to social determinants of health, we were able to have a substantial increase in initiation of treatment and linkage to aftercare for continuity care after they left the hospital.
It's also really interesting to me that you could do that while people were in the hospital for some other reason. I mean, they were acutely sick to be in the hospital, and still you were able to connect them to treatment for the substance use disorder.
Yeah, I mean, it's part of why we think that the hospital is actually a perfect opportunity, because you catch people that aren't otherwise looking to get into treatment. We talk a lot about overdose deaths, and we should, because there's over 80,000 a year alone due to opioids. However, for every person that dies of an overdose, there are many people that recover from overdoses or they get medical treatment that don't die or have other significant health consequences from their substance use. Those people often end up in hospitals, and that's such a critical opportunity to be able to engage them in making changes in their lives for the betterment of their health. And so even though a lot of patients that we approached were not necessarily seeking to get care, we were struck by how receptive patients were, A, to participating in a study, and then B, if they were randomized to the intervention, actually engaging in the intervention.
I wonder if I could turn to Mike now and ask, because this sort of is a nice segue to the study that you did, which really looked at that kind of window of opportunity of a medical hospitalization for people with substance use disorders. If you could talk a little bit about that and what you found.
Absolutely. Thank you, Eve. We know, as Itai said, that hospitalizations can really be a double-edged sword for patients with substance use disorders. On one hand, absolutely there are opportunities to engage folks into treatment and linkage to community care. But on the other hand, they can be quite destabilizing for patients because they're leaving the hospital debilitated from their acute illness, perhaps with a lower opioid tolerance than they had previously, and facing a whole host of psychosocial and environmental barriers to linking to care in the community once they leave. And so what we did is we identified a large cohort of veterans with opioid use disorder who had experienced a hospitalization over a 10-year period, looked at how many of those individuals had died during a 1-year observation window after hospitalization, and then really kind of sliced that year into thinner slices to see what time interval after discharge had the highest risk of death among this group of veterans with opioid use disorder.
And tell us a little bit about what you found, because to me it really sort of brought home that this is an important time to intervene.
Absolutely. And so what we found was that the risk of dying in the first week after hospitalization was nearly 3 times as high as dying in an interval that came later in that year from 91 to 365 days. And that was true of both all-cause mortality, because as we know, people with opioid use disorder get hospitalized for all kinds of things that aren't necessarily directly related to opioid use, and also opioid-related mortality, things like overdose. So really drives home the importance of interventions like the one that Itai is describing that provide intensive support during that immediate post-hospitalization period where we know that patients are at highest risk and their very survival depends on it in many cases.
I wonder if either of you has thoughts about what the next steps are in terms of either research or clinically implementing some of these findings to help us better take care of patients who are hospitalized with opioid use disorder and then followed afterwards.
I could jump in first. I mean, Michael's study highlights the importance of having interventions in the community after people leave the hospital, because we know for substance use treatments in general, you need to have continued retention and treatment to get the benefits over time from them. So we showed with our study that you could effectively link people to aftercare, and over 70% of the socially disenfranchised population actually did link to care, but then you need to retain them, in care. So we definitely need a lot more work to figure out how to retain and continuing to engage people in care. And then on the hospital side, I think we really need to change the expectation for what happens in the hospital. And we need to get hospitals to recognize that substance use disorders are treatable conditions like many other chronic illnesses that have acute exacerbations that present to hospitals. So just like if somebody presented to a hospital with diabetic ketoacidosis, it wouldn't be enough to just treat the ketoacidosis and then send the person home with a list of referrals for continued care. We understand that we have to initiate treatment to continue to lower that person's blood sugar and treat their diabetes and then get them connected to a continuing care model. We need to do the same thing for substance use disorders, and we need to establish quality metrics and incentive mechanisms to reinforce and encourage hospitals to do that.
I would just add that I think the science of inpatient innovations in increasing initiation and access to addiction treatment is really growing with a strong evidence base and with really exciting programs like the one that Itai you designed and studied. As a primary care doctor and outpatient addiction provider, I feel like some of the inpatient innovations have a little outpaced the science on the outpatient side. And I'm really interested in more partnerships, how outpatient care teams can partner with inpatient care teams, either through InReach or through kind of a liaison sort of model to really strengthen that care linkage. So once patients walk outside the door from the hospital, there's a whole team, a whole infrastructure helping them to overcome any barriers that they may face in connecting to longitudinal care and then keeping them in care. These need to be, I think, longitudinal interventions. And I personally think that primary care is such a great place for so many patients to receive that kind of integrated longitudinal medical and substance use disorder treatment in partnership with addiction consult teams and other inpatient-based interventions.
That's such an important point. I sometimes like to end just with like a clinical pearl, maybe for the practicing internist, either a hospitalist or a primary care doctor, to sort of take away from this. Do you have something that you would share as we wait for the innovative, full sort of partnerships and ideal settings that of course we want, but is there something in the interim that people might bite off as a doable next step?
Yeah, I think for inpatient providers, just making sure that all the follow-up appointments are scheduled and printed out for the patient and in their hands at the time that they leave, and that there's a contingency plan. If something comes up and you're not able to make this particular follow-up, here's a number to call, or here's a kind of a low barrier clinic where you can go and preserve your access to care and get looped back in to longitudinal care. I think sometimes what happens is patients are left to their own devices to call and schedule follow-up, and that can be weeks down the road. So I just think taking that extra step to get things all set up for patients before they leave the hospital and in their hands is a good clinical pearl for hospital care teams.
Yeah, and I would just add that our colleagues in medicine and in psychiatry and surgery are overwhelmed with so many responsibilities and so many conditions they have to care for. And so it can sometimes feel like adding another thing. We talk about, hey, substance use disorders should be treated as well. But I think the clinical pearl is it's actually so much easier and more rewarding to manage individuals, people that have substance use disorder when you're actually treating the substance use disorder than when you're not, than when you're trying not to deal with it, when you're hoping somebody else will. And the interventions that are available for physicians to deliver are effective and they're very doable. And a lot of the interventions that exist support people getting comfortable, but once they get comfortable, generally continuing them and continuing to learn how to do them is self-reinforcing. So I would just encourage folks to give it a try and to reach out to somebody in your community of physicians if you need some expertise or guidance on how to do it. There's a lot of resources that are available. The manual for our study is going to be published soon, and there's many other guidances for acute care settings on how to start medication treatments for opioid use disorders and other substance use disorder, alcohol use disorder, which is huge, and the many other conditions. So just jump in.
Well, thank you both so much. I'm learning so much. I feel like I could talk to you all day, but I unfortunately can't do that. So again, just thank you both so much. I'm Dr. Eve Rittenberg. I've been speaking with Dr. Itai Danovitch and Dr. Michael Incze about opioid use disorder and a promising approach to improving treatment. You can find a link to the articles we discussed in this episode's description. And this episode was produced by Daniel Morrow at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.